Good morning. Welcome to the critical appraisal sessions as a part of the short course in epidemiology. Today we will be looking at cross-sectional study design, which we have not done in quite a while. So it is a kind of an observational study. So Dr. Sakshi has done a critical appraisal of a cross-sectional study on an Indian population, which has been on rabies prevalence. So I will leave it to Dr. Sakshi to go through the critical appraisal as part one of this session. Thanks, Dr.
Sakshi. Good morning, everyone. So today I'll be talking about how one appraises a cross-section study. Before going to that, I just want to familiarize everyone with what a cross-section study is. Because mostly we deal with a lot of longitudinal studies, case control cohort, RCTs, which we are used to analyzing, but we are not sure as to how to analyze a cross-section study. So coming to cross-section studies in the hierarchy of evidences that are available for any literature, cross-section comes just above case reports and case series, and below are cohort studies, case control studies, non-randomized trials. Although the level of evidence that in the hierarchy of evidence is lower down on the list, it's not. It's an important tool that we have because some studies can be only done through a cross-sectional methodology. So coming to how cross-sectional methodology is different from a longitudinal study, if you see here in the cross-sectional study, there are multiple groups that are studied at the same time and at a snapshot of time. So you don't follow up these people at a given point. Different groups are observed without doing any intervention. So you're not influencing the group that you're studying, but just by observing, you try to analyze what the data that you are getting. As opposed to longitudinal study where you follow a homogeneous group of population. It's not different groups that you're following a homogeneous group of population over time. So at different times you're following up the same group of people. This may be interventional or non-interventional, and you're trying to see the trends that occur in that group or any outcome that is occurring in that group over time. So that's the difference between cross-sectional and longitudinal. So cross-section is at a given point of time you're trying to see various groups, how they're functioning at a given point of time, whereas longitudinal is more for homogeneous groups. So here, just like I said, now because you're seeing different groups at a given point of time, cross-sectional study is best for prevalence study. So if you want to know the prevalence of a certain disease, let's say India is trying to start a public health program on diabetes and obesity. So if you want to see the prevalence of obesity in diabetic patients, the best way to do it is through a cross-sectional study because that will be able to give you prevalence of obesity in such patients. However, longitudinal study, because it's over time study, it will not be able to give you prevalence of certain things. Now, when it comes to cross-sectional study, because you are doing multiple groups at the same time, you can analyze multiple variables, you can analyze multiple exposures and multiple outcomes together. However, it gives only a correlation value. It will not tell you causation. So you can say that maybe this group of people are more likely to develop obesity and diabetes as compared to people who are sedentary. But it will not be able to tell you for sure that okay, sedentary lifestyle does cause obesity. So it's a causation. The causation cannot be established, but you may be able to develop some correlation which will help you develop hypothesis to do a longitudinal study later on. Now, when it comes to cross-section study, you can have it both descriptive or analytical. Descriptive study is when you're just describing, okay, these many men are there in population, this is the age group of the population. Analytical is when you try to get odds ratio. So when you try to establish correlation between two variables, that's when you have an analytical cross-section study. So coming to how you do sampling in those studies. So let's say generally cross-section studies done for a very wide range of people. So you have a target population. Most of the cross-section studies are done as census or population-based studies. So generally the entire population is what you're looking at in cross-section study. From there you try to develop a study population. So there are multiple ways of sampling to develop the study population, which may be probability-based sampling or non-probability-based sampling. When you have a probability-based sampling, each participant or let's say each individual has equal likelihood of being into the study. Now, multiple ways of doing probability sampling include simple random sampling, stratified random sampling, cluster sampling, which is very commonly used in cross-sectional method, or you can do multi-stage sampling. So those are probability-based sampling. When you are looking at non-probability based sampling, you can have something called as convenience sampling, where let's say because you are in a tertiary care hospital and these are the people that come to you, you try to do convenience sampling. I will take only these population, people who are coming to me, and try to see if they are generalizable to the entire population or not. So that is convenience based sampling. You can also have snowballing method of sampling, which is also non-probability based, where you pick one person and based on the reference of that person you pick the next set of people. Then based on their reference you pick and so on. So that is snowball method. Those are non-probability based. Obviously probability based sampling will be much better because each individual has more likelihood of being in the study and therefore it will be more representative of your target population. So here you have the target population. Based on your sampling studies, you get a study population, which is a sampling frame. From the study population, you select your study participants. So those are your study participants. Again, each study participant should have equal likelihood from the study population to be represented into the study, and they should be representative of the target population that you have. Now coming to cross-sectional study, so here like I said, you measure the exposure and the outcomes at the same time. So you are measuring both whether in the given population someone has diabetes or not, and in that population whether someone has obesity or not. So your exposure and outcome is measured at the same time. Therefore you can only establish correlation and not causation. Now, advantages and disadvantages, some of them I've already mentioned. Advantages, it's cheaper, it's less time consuming. You can analyze multiple variables, multiple exposures and outcomes at a given time. It captures a specific moment, therefore it's good for consensus studies, prevalence studies, and it's a good method to develop hypothesis to test in longitudinal studies. Disadvantages is it cannot establish causality. It cannot establish long-term behaviors or trends in a certain variable. It may not be representative of the behavior being studied if your sampling is not good. So that's an inherent problem with this kind of study. It cannot measure the incidence of a given outcome. It can only tell you the prevalence. And it may have some reporting bias because it's mostly descriptive and analytical. So the person who's reporting it, their biases come into play when they are doing the final discussion and conclusion. So how does one write a cross-sectional study and how do you appraise an already written cross-sectional study? There are multiple guidelines. So the most common guideline to write a study is stroke guideline, which is available freely on multiple websites. Then the next tool is Access. So we don't have any task checklist or drama checklist that's generally used for most of our analysis. So here, this was published in BMJ Medicine, where Access tool was developed. This is appraisal tool for cross-sectional studies, which is a 20 questionnaire checklist which we will go through to understand what it's about. There's another shorter questionnaire of 8 questions developed by JBI for analysis of analytical cross-section studies. Actually, that was mostly developed to see whether you can include certain cross-section studies into a systematic review or not. So it's a shorter, more compressed version of similar Access tool that you already have. So before we go on to the journal, this is a case scenario that's there with us. So now WHO wants, India has established a national action plan for a dog-mediated rabies elimination by 2030. Now before they actually go into that, what steps to come up with, you need to know the baseline data. So what is the prevalence of dog bites, how many people actually die of dog bites, and they found that those studies are lacking. The last one was updated in 2015. So there was a need to do another study to see the current prevalence rates and practices. So this was a study which was published in Lancet Infectious Disease Journal recently on September 30th of last month, which talks about estimates of the burden of human rabies death and animal bites in India in the year 2022 to 2023. It's a community-based cross-sectional survey and probability decision tree modeling study. I will come to what the second part of the research is about, the probability decision tree modeling. So how do you proceed? Like, what are the variables that you would want to know in this study? Or if you were conducting it, what are the variables that you would have wanted to include?
Number of, how many people got bitten by
Okay, so number of animal bites and which animal bites, how many dog bites, then?
rabies.
How many people were actually affected with rabies finally? Yes. site of the bite?
Where the bites were happening.
Okay, so what population was getting the bite?
How will we capture it also would be very challenging. We go to audience systems or...
So what methodology will be used to sample the population?
Outcomes of patients.
Okay, outcomes of patients who actually got bitten.
How many were vaccinated?
How many were vaccinated?
Finished and completed the course of
Okay,
vaccination.
so how many started vaccination? How many completed the course of vaccination?
Also, like if any already some plan was in place for vaccination of the stray dogs or
Okay, so animal vaccination. So whether the dogs were vaccinated or not. Okay, so we'll go through the study and see if they have included these relevant points. So one way to always analyze the studies to see how you would have done your study and see whether those things were included in the study that was done or not. So coming to the questionnaire, so how this is gone is you check the aim, you check the methodology section whether that was appropriate or not. Then you go into the results and then discussions and limitations. So that's how the analytical tool, the access tool is structured. So coming to the aim, what you need to look at is whether the rationale of the study was adequate or not. Whether the study will actually contribute anything into the current literature or not. Second is whether it's an appropriate and focused question or not. So here, based on our case scenario, they had similar question as to whether the prevalence, what is the prevalence currently, what is the vaccination coverage, what are the vaccination practices. So the aim of the study here was to estimate the annual bite burden, the number of human babies death, and post-exposure prophylaxis coverage in India. So if you think about in terms of a PICO statement, they have explained the population, they have explained the exposure, they have explained the outcome. What do you think the time here will be in the PICO statement? Correct. So it's a snapshot set. So the time interval won't be 2022 to 2023. It'll actually be at the given time that the interview was taken, the survey was done. So how was the study design appropriate for the stated aim? So you want to look at whether cross-section study is the correct study to do here. Because this is a prevalence study in Indian population, it's a correct methodology to pick. Here they have done it across India, across 788 districts, among 28 states. So was the sample size justified? I'll come back to that after looking at the methodology and how they have picked the sample. So was the target population clearly defined? Again, because here India is what they are looking at, that's the target population. However, if there are other studies, we want to look at whether the population that they are defining is adequately representing the outcome that we are looking at. Now, was the sample frame taken from an appropriate population base so that it closely represented the target population? Again, like how mentioned earlier, whether your sampling frame that you've made or the study population that you've checked is representative of the target population so that you can generalize your result that you get from the study to the population. Here, they have used what is called as a multi-stage cluster sampling design. So, what they have done is, they have divided India into 5 geographical regions. That's North, West, East, South and Northeast. Now, among these 5 geographical regions, they have done simple random sampling to pick 3 states in each region. So, across India, they have picked 15 states, 3 from each region. After that, from each of these states, they have picked 4 districts in each of the states based on probability proportional to size. So that is a sampling technique where based on the proportion of that area, you pick them into the study so that the population in that area is likely to be represented as equally as to the population that's in a smaller area. So based on that proportion, they form a probability and then select the 4 districts. So each state then had 4 districts, making 12 districts in each geographical region. Then from these districts, they again based on probability by proportion, they have selected 10 clusters. So from each of the 4 districts, 10 clusters have been selected from each of them. And they can be either villages or wards, trying to cover both rural or urban population. Then from each of these clusters, they have selected one census enumeration block by simple random sampling again. After that, in each of these census enumeration block, they have found households. So approximately each of this CED has around 130 to 150 households, and they have tried to include that as their sampling unit and said that we will sample households to get individual sampling done. So instead of taking individuals of around 3 lakhs, 4 lakhs, they have tried to reduce it to households, and then based on the households, they have selected the entire population. Is that clear? So, was the selection process likely to select subjects that were representative of the target population? Now, after you develop that sampling frame, when you are selecting individuals or study participants, you want to make sure that those are also representative of the total population. So, here you want to look at what was the inclusion and exclusion criteria, if any, that they have included. Whether the sampling is enough or is representative of your target population so that you can generalize the results that you get from the study. Then whether there was any selection bias. So this selection bias can be from the investigator or from the participants itself. For example, say I'm circulating a survey about obesity and its risk factors. People who are obese may not be likely to answer those questions. So that will cause self-selection, in which case they may not reply to your survey. Whereas when you are selecting, you sometimes miss people who are obese because let's say you want to show that India's obesity is not that bad. So that can be selection bias from the survey itself. So you have to look at whether there was any chance of that having happened and how they finally reached to the sample or the study participants. So here they mentioned that simple random sampling is used at 2 levels, and once they have reached the enumeration, census enumeration block, they have started, so among the 130 or 150 households that were there, they have randomly selected one of those households and then gone around surveying all the households till their sample size in that cluster is over or not. So this is the consortium that they have shown. So they have taken 15 states with 5 regions. And then each cluster, study cluster, they are supposed to, they have interviewed these many households, visited these many households. Then some households were non-responders because either their doors were locked or they did not want to participate in the study, or they did not have any household members there, or they have an incompetent respondent which they have not explained about. So there were certain exclusions, and after that, out of the total number of households that they have visited, 91.2% of households were surveyed, and that comprised of 337 individuals totally. So that's how they have come to the entire sampling size. So just to look at what are the baseline characteristics of the study participants. Most of the age group was between 15 to 60, which was around 68.3%. Men and women were equally distributed around 50 and 49%. Now, how they have surveyed in each household is they have surveyed the head of the member in that household. And head of the household they have described as people who either take care of the house or financially support the house. And then they have mentioned their education, their occupation. At the end, they've also mentioned type of house and toilet facility, I'm guessing to indicate rural, urban situation. So, whether this sampling study that they have done is indicative of our Indian population, they have compared with the 2011 census population, and it is similar. So, it looks like whatever the study participants that they have selected is actually representative of the target population that we are looking at. Yeah.
How do you say
it's mostly similar, except I thought the age here. Apart from that, gender was fairly okay. The rural urban was similar. So I thought it may be equal.
That's the last census, right?
We don't have any census here.
That's the only we can go. Sure.
So now coming back to whether the sample size was justified or not. So what they have done is they've taken annual by incidence of 1.7% based on some previous literature, and they've taken a relative margin of error on that annual incidence of 10%. Then they've taken a design effect of 2%. So when you do cluster sampling, there is some changes in the population or in your sampling that can happen. To adjust for that, you have to increase your sample size. So that's what design effect is for, that increases the sample size. Then they've taken an alpha error of 5%, and they've taken non-response as 15%, or attrition rate as 15%, based on which they've gotten a sample of 52,000 per geographical region. So that comes to around 25, 26, sorry, 2,50,000, 2,60,000. Now what they've done is, they have divided, they have from, again, census, they have the minimum household size is 3.5 people. That's the average that they found. And they figured that they need to cover 15,000 households. So 52 by 3.5 is around 15,000 households in each region. That means 5,000 per state. So if we take 15,000 households, in one region, they have 120 households, or 120 cluster blocks. So from that, they have come to 140 households. Actually, it comes to around 125 households in each cluster, but they have increased that size and put as 140 households.
Design effect is important. Because if you do clusters, let's say a family, you're doing lifestyle. Every member of the family like to have similar food and exercise habits. So they actually behave similar. So it's not big fights, I think like they have numbers. So they're all, we look at studies, we hope each person's individual. Their behavior is not influenced by the next person's behavior or stuff. That's a problem with the cluster randomization because in the cluster people tend to behave similar. So it's not, you're not getting the full benefit of having individually sampled people. So you have to increase the sample size for that cluster effect. So that design effect normally is 2%, 3%. Some people just double the sample size and say that design effect is 2. But it's just taking into effect that when you take a cluster, let's say in a family that maybe 2 children are dog bite, or the similar kind of habits which led them to a dog bite, or in a village where there are a lot of dogs playing. So that is the design effect. So when you do cluster sampling, we have to always take into account the design.
So next is where measures undertaken to address and categorize non-responders. So ideally, you have to have a prior plan as to address how you would deal with non-responders. Why that is important is because multiple people can refuse, cannot be contacted, or details may not be there for your participants, which may cause a non-responder bias in your study. So your response rate that you get, or the population that you get who are responding may not be a true reflection of your target population. Therefore, how many people have actually not responded is something that's necessary to know. Also, if you have to have a prior plan. So, for example, when you have surveys like this which go to households, you can have a plan saying if there is no response in first go, I will go 2 more times and see if that household responds or not. If it doesn't respond, I'll change and get a third household. So that's how you can plan for non-responders earlier. Other thing that you need to adjust is in your sample size. So you have to adjust in your sample size, saying I'm expecting these many non-responses, and therefore I'm increasing my sample size already. So here they've not mentioned how they will deal with households that do not answer, but they have mentioned that they have done an adjustment factor of 50% in the sample size for non-responders. So now, what the risk factors and outcome variables measured appropriately. This is something called as indicative of validity of your study. So what you want to know is the instrument or the measurement that you are taking is actually valid for the outcome or risk factor that you are assessing. For example, here when you are doing mostly whether someone was bitten or not, whether they have taken vaccination or not, a survey is good enough to get the risk factors and the outcomes that you are looking at. However, if you are looking at, say, obesity, so you may want to choose BMI. In that case, whether you want to measure height in meters, whether you want to measure height in centimeters, all of that is important because it may change the result that you are getting. If you don't use the correct measurements, there's something called as misclassification bias that happens. So let's say Asian BMI cutoffs are different compared to the world BMI cutoffs. So if you don't use the correct classification, you may classify someone as overweight as compared to obese, or you may just misclassify them. Thus your final result may actually be not correct, as in your correlation may not be correct. So here they've used a survey questionnaire, which is an appropriate tool. Survey questionnaire inherent problems that people may have called bias. To decide whether the rabbit or the dog bites that they have, whether it was from suspected rabid dogs or not, they have used some real-time observing the dog for 30 days or so. And for the dogs that they could not observe, they have used some estimates based on 6 lab results across India. For number of human rabies bite deaths, they have looked at something called as WHO decision tree probability model based on certain factors that will come to when we are talking about the decisions. Now, were the risk factor and outcome variables measured correctly using measurements that had been tried, piloted, and published previously? This is indicative of the reliability of the study. So, if different people repeat the measurements, or different people repeat the study, are they more likely to get similar results? That's what we are looking at through this question. What you want to know is whether the measurements that are used are standardized measurements, whether they have international units or not, and if they have used certain criteria, whether those criteria were validated earlier or not, and whether they have been already published or not. So for something that, for people who make questionnaires or survey tools, one thing to mention is whether the survey tool was piloted before or not in a small group of people and then adjusted to conduct a further study. Here they have not mentioned about piloting of the questionnaire, so that's something that I would have liked to know from this study. However, they have mentioned that the surveyors who went into the field and surveyed people have been trained beforehand, and the criteria that they use to distinguish between non-rabid and rabid dogs and the WHO precision, the decision tree model that they have used, both have been published and validated before. So, is it clear what was used to determine the statistical significance of sufficient estimates? We want to know whether correct statistical methods or not. Here they have looked into proportions, mean, standardization, median, IQR where applicable, and talked about 95% confidence interval for the descriptive analysis. Then coming to non-receipt of vaccination, they have used univariable and then multivariable logistical regression analysis. And they have mentioned that the model that finally went into establishing the multivariable logistic regression used variables from the univariable analysis with a p-value of less than 0.2. At the end, from the decision tree model, they have mentioned 95% uncertainty intervals for the estimated human rabies deaths. So, were the methods sufficiently described to enable them to be repeated? So, here again, you want to know whether the methodology that they have mentioned is robust and whether you can repeat them similarly. And I thought it was well written and it's very clear as to what they have done. So, coming to funding sources or any conflicts of interest, because that's important to know, as their reporting can be influenced by where the study was funded from and what are the interests of the authors that are publishing the study. So this is an ICMR funded study and has been published in Lancet on the 30th September 2024. The date of submission of the journal has not been mentioned. The authors at the bottom have declared that there were no conflicts of interest. So, was ethical approval obtained and consent of participants again? They mentioned that they have got a human ethics committee from the ICMR NEI and the particular participating institutions also to approve the study protocol. They've gotten written informed consents from participants older than 18, parental consent from those younger than 17 years, and from 7 to 17 they've gotten assent for the participation. One thing that I thought was not mentioned is they are getting data from animal laboratories, so whether those data they have gotten consent for is not mentioned anywhere in the article. So based on this, I thought the methodology was quite sound and we can go into looking at results and see what the results were finally. So when you look at results, you need to look at whether all the basic data was described properly or not for all the variables that they have mentioned. And this gives an overall idea about whether there are any differences or potential differences between different groups or different variables. Then does the response rate raise concern about non-response bias? So as earlier on the show figure, we have 8.8 non-responders, which is not too bad considering they thought it may be up to 15%. And it may not really affect the study so much. Coming to if there are significant non-responders, you want to know what are the people who have likely to not have responded. Here they have mentioned why there were certain households that have not responded. I think it was fairly okay given that 7% may not be there in the household when the survey was taken. However, one thing that they mentioned is incompetent respondents. So that again is not very clear. Maybe that someone doesn't want to survey that household, so that may be an area where bias can come. But otherwise, it was okay. So were the results internally consistent? Here, what you want to look at is whether there were any missing data, whether all the analysis matches the consort diagram and the final number that they have stated, and it does in this study. So were the results presented for all the analysis described in the lecture? So why this is important is sometimes they will analyze something, and if they get a negative result, or a result that is not in favor of the funding agency or the participant authors, they may not want to highlight it or they may not want to publish it. So that's why you want to check that whether all the things that are analyzed have been published or not. So coming to the results, certain things that I thought. So this is characteristics of all the biting animals in the profile of the bites. So animal bites total in the past 1 year was around 2,000, out of which the dog bites that were reported is around 1,576. They said it's a little lower than the annual incidence that they have considered in their sample size. Then again, the different biting animals apart from dogs are cats, monkeys, rats and other household animals or wild animals. Then the category of dogs, so the dogs that bit, 39% of them were pet dogs and stray dogs were around 61%. They said that most of these bites were unprovoked bites. So that is something that, I don't know, for me it did not sit well, and I would have wanted to know whether those unprovoked bites were mostly by suspected rabid dogs or not, which they have not clarified about. Then they have tried to follow the dog for 10 days to see how the dog's course is. And out of that, only 72% were available for follow-up. The rest of them, out of these 72%, 93% were alive, 2.7% died, killed was 1.9%, and not known status was 2.2%. Then the rest of this, so this is 72%, so they have tried to see whether they were suspected rabid dogs or not from this. The rest of the 30% that they have tried to get suspected rabid dogs or not from a criteria which I'll come to subsequently. Then the number of wounds, most of them had one wound, and the commonest site of bite was lower lip, that was around 68%. Some around 2.8% people had head or face bites also. Now types of wounds, very unlikely that people would have reported category 1 wounds. So most of them were category 2 or 3, out of which 65% were category 2 wounds and the rest were category 3 wounds. So that's how they have given a characteristics of biting the animal profile of the bite, which I thought was exhaustive and covered most of the points that we discussed, we wanted in the study. Then coming to how people responded to the bites, what was the wound management and what was the vaccination policy, or how many people sought vaccination. So around 53% washed with water and soap. However, 17.5% people did use some locally available applications, which included chili powder, turmeric powder, some other stuff like mud, coffee powder, which may have increased the irritability of the wound. Then ARV coverage. So if you can see, I mean, out of the 20.5% people did not seek any vaccination at all. Out of the people who sought vaccination also, only 40% completed their course of vaccination. So 60% people who did seek vaccination did not complete the course, whether it was 4 or 5 as determined by the local public health facility which they went to. Then type of health facility, among 90% people was public health facility and not private. Route of administration, 66% was intradermal, and site of ARV vaccination mostly was in the deltoid region. As when it came to immunoglobulins, so if you remember, our category 3 groups were around 35%. Only 5.1% of the total population received immunoglobulin, which is much lower than what is actually required now. And so where baby's immunoglobulin was given was mostly for category 3 wounds. Some 2% people also got it for abrasion as well. Now, reasons for why people did not get vaccination. Around 56% said they were not aware of vaccination being available, or they did not know where to get the vaccine. Certain population, around 9.3%, also did not believe in the vaccine being helpful. When it came to rabies immunoglobulin, most of it was given into the wound, and into the that's around 60% was given only into the wound and not into any other areas. Coming to the dog side, I wanted to look at how many pet dogs were vaccinated. So only 51% of pet dogs were vaccinated, others were not vaccinated. And the 25% population owned pets, out of which 18 were dogs. What I was wondering is, I'm sure you have taken what happened to these people who got animal bites. Like that information would have been there in the survey. It's very unlikely that we would have gone asked what happened, who got animal bites, and not asked what happened to those people. But they've not really published that data anywhere or not mentioned that. That's something I would have wanted to know, but they have not mentioned in this time. Now coming to the analysis, so based on the data, they calculated the annual incidence per 1,000 people of animal bites is 9.1 million bites, and for specifically dog bites, they've calculated 5.6 per 1,000 people. Based on the age, gender, type of residence, again they've distributed. And as you can see, children or adults more than 8 to 60 are more likely to get dog bites. Male more than female, but that again can be because men go outside home more than women. And rural people more likely to get compared to urban population. When it came to dog bites,
age, elderly people are taking, I think the children is very well described. More than 60 would be. I never thought of this population being the highest. Children, of course, I guess.
I have to say that
Not close to
You can even move away from
ambulance is an important issue.
There's something I've heard of.
Like 9 million is not meant for 1,000. 9 million is like overall.
Overall, yes.
But it's 6 per 1,000.
6.6 per 1,000, 9 million bites is the overall estimate. Yeah. When it came to how many people received ARV post dog bite, there around 40% received all the doses and 80% received at least one dose of ARV. The time duration from the bite to the ARV was not mentioned in the study either. Then again RIG, again only 5% of the population actually received RIG. So coming to the analysis of why there was not receipt of vaccinations, they found certain things. So I have highlighted things which have come positive in the multivariable analysis. Here they have looked at region-wise, the north, northeast, and west population is more likely to not receive the ARV. The odds, adjusted odds ratio was around 5 for both north and northeastern areas, and for west it was 4. Then for the type of wound, they realized that if patient had only category 2 or abrasions alone, they were 2 times more unlikely to get the vaccination as compared to patients who have laceration or puncture wounds or higher abrasions. Then if you look at dog type, again, if it was a pet animal, they were more likely to not have taken the vaccination. However, given that around only 51% of pet dogs are vaccinated, this may be an area that we need to highlight more while disseminating information. Something that they found significant was type of house, Kachra house being more likely to not take vaccination. But again, I did not understand the correlation as to why. I mean, it may be that it's a rural population, less literacy or less access to healthcare per se. But again, those things actually did not come significant in the univariable analysis. So that's something we need to keep in mind when we are interpreting this result. So coming to the 2 things as to how they finally came up to the number.
values.
It's more reflection of sample size. They're taking
That's
thousands
right.
of people now.
Yeah.
We should not interpret p-value as this how significant. Odds ratio is more important.
No.
We should not look at the p-value significant. That's simply related thousands and thousands of the p-values are made. But the odds ratios are significant.
The confidence interval for most of them, all of them do not cross 1.
Yeah. So that won't be significant. But it's not very high confidence in either. It's significant. North is quite a huge difference from south.
Actually, when I looked at the appendix, the number of annual bites per region was more in the south compared to other areas. But the vaccination status was definitely much better in the south compared to other regions.
Because there are more eyes, the awareness may also be more of the public health will be tested.
Or literacy also, awareness also.
Why is South the reference?
So south is not the reference. South's OR is 1 to 3.
No, that is we do a comparison. We compare against somebody. They have chosen different, so we have to explain why they chose.
Yeah. So the other way to look at it would be to compare across all 5
All 5.
and see whether present the overall T and see whether that.
But even when you do multiple comparison, there's one group, like there's no placebo group, like asking. When you're doing this kind of cross-section, you have to use the reference category.
Here they chose the best.
So if you, so now they're saying that they are trying to present which group has less vaccine, worse outcome, not better outcome. If you put which group has, which is having better, if you put North as the reference category, or Northeast, everybody's oscillation would be less than that. So they are doing better than the worst. There I want to show, they try to present a message which group is doing worse. So you use the best group and then you try to draw the oscillation or the higher oscillation.
So that is basically based on the percentage that they saw.
The odds is 5 times more, 7 times more, 2 times
So
more.
it's how this South they chose because the percentage was lower. Is that why they
No,
chose?
they're saying that South has the highest percentage of vaccination. Usually you must plan this before the analysis. You can't, after the analysis, you can't say, I'll make this a reference. Okay, South probably has a nice vaccine. So we'll call that the reference category. All the oscillations are compared to that. Even that, you can say the doctor house or something. But even the dog type, okay, we take this people who are straight up by the more likely to be vaccinated. So we call them the reference category. Compared to them, what is the risk if the people who had the so you have to actually think about what you're doing on the reference. Because you have to choose carefully which is going to be the reference category.
So now so this is the WHO decision thing. Okay, so how they have decided is first they have taken people who got the bites, whether it was a suspected rabies bite or not a suspected rabies bite. So for people who are not suspected rabies bite, it's out of the algorithm. How they have decided that? One is they have observed the dog, so that's around 70%. So if they were alive and not rabid or not showing symptoms of rabies in dogs, they have excluded that. For the rest of the 30%, where they did not know the status of the dog or they could not locate the dog, they have followed this algorithm. Basically, they have tried to, one is categorized based on these things. Second is from the estimates that they got from the 6 to 7 laboratories, they have tried to extrapolate that. So that's the 2 ways they have tried to get the incidence of or suspected rabid dogs. After that, they have gone into where the bites were. So based on the bites, that's point estimates of P, probability 2, probability 3, 4 and 5. So whether it was on head or neck, hand or arm, torso and leg or foot, they have decided, gone into that. Then from there, they have gone into what is the probability of getting rabies in that bite site, which they have gotten from multiple literature. So based on this, then finally, once they get this, then we look at whether the patient was vaccinated or not vaccinated. And then what is the probability of them getting rabies. they have come to this final decision model. So this, what they have gotten here is probability of death. So the PD that they have calculated is from this decision model, and then they have taken the incidence of suspected rabid bite dog, and then they have taken at-risk population, which is the entire population of India. Based on this, using a formula that they have calculated the number of human rabies deaths.
Can you explain that also?
Sure. So,
Just so that I will be clear.
So based on the WHO decision tree model, they need three things to figure out what is the number of human rabies deaths. One is the probability of death if someone got a dog bite. Second is incidence of suspected rabid dog bite in the population and at-risk population. So these are the three variables they need to determine what is the number of human rabies deaths in 1 year. Now how they have gotten each at-risk population, they got from the census population of India. Then incidence of suspected rabid bite dog, they have calculated from this. So out of the 70% they had dogs who they could observe, and 30% they did not have values on. So this 30% they have gotten from estimates from 6 labs across India as to how many test positivity do they get per year. Based on that, they have gotten results for 30% of the dogs that of the information that was not available. They have extrapolated from whatever these labs generally test positive for, what is their rate of positivity. And for the 70%, they followed this. This is a 6-step criteria which is published by Dexamethasone et al. So if of the 70% dogs which were alive, then they could follow. If they were alive, they were non-rabid. If the status of the dog was died, then they classified as rabid. If others, that's either they are not known or was killed by people before, then they calculate based on the age of dog, status of health of the dog prior to that. How did the illness evolve? How was the condition during the clinical course, if they could see? Does the dog show signs of suckling, which is an indication of rabies in them? And does the dog show at least 2 of the 18 signs and symptoms determined before?
So based, they got a number of bites from the this
Correct.
which was each of the bites they tried to say that okay, this was probably a rabbit bite and this was probably a not rabbit
Yes.
bite. And from that they calculated okay, these were probably rabies. And based on data on rabbit bites, how many deaths are there, they said okay, the probability of death in the population due to rabies.
So that is the total that you are looking at here.
But the probability of death is
Probability of death is based on the WHO decision model, which we are looking at.
The deaths didn't come from this particular study.
Yeah.
Go to the household and ask me to talk to your doctor, and then you get out of that. They didn't take that death to come to the number of babies there. For some reason, they have not taken that data. They have taken a decision, which is like, okay, what is the probability of dog biting something? 6%. What is the probability of that dog being a baby dog? Then, okay, to the baby dog, what is the probability of the person having had the dog by having vaccine immediately or not? Then, what is the probability of the dog biting after the or in high risk? So, you make a decision tree like that. And each time is a probability. The person will dog bite you or not. If the dog will was baby or not. If it's baby, then what's the probability of biting you other than the baby? If it did you, what is the probability you will vaccine or not, or immunotherapy or not? And finally, you come to the probability of you having been bitten by a baby dog and getting rabies, then 100%. So this is the decision tree modeling. At the end of it, you come to estimate, okay, among all the people in India, this is the likely estimate the number of rabies deaths. Why they didn't take the deaths from their own cross-section, where they interviewed people with a dog bite 70-75. For some reason, they have not taken that. They have preferred to do this modeling. This is a model. This is the likely estimate of the number of people. But the model depends on your assumptions. Okay, 6% of people will, how do it not 25%? Then the estimate is the chance of it being rated is 30%. It may be 40%, it may be 50%. Then it will be between the upper and lower model of properties. So what they do is they say 30%, but they also see what happens with 10 or 20. So every of these points in the decision tree, they do a little bit of a probable error margin. And finally, including all the others, it will be a final estimate, the number of deaths you will be able to release could be ranged from year to year.
What they mentioned is, from the survey they found these many number of confirmed rabies deaths in past 5 years. And if they calculate that, their estimate is also coming around 5,000 per year. So, why they have not mentioned that data at all anywhere else is something I was also not clear about.
So is that number of probability of death? So that is probability of death if somebody gets a dog bite. Is that what that
No, overall in India, in the last 1 year, 5,000 people were
So,
No, this probability of death is yes.
That's what I saw from the last one.
When we do a simple random selection, like a model like this, do we assume that the burden is distributed equally? Is that one of the basic assumptions within the model? Because I am asking this because the number they are quoting is about 1/10 of what was the proposed number. And I'm a little worried. This is a very good design to see how much bites are happening. But to conclude that how many deaths are happening,
There's no other way.
Yeah.
Usually in India, you have to take a sample. In the sample, how we take samples? So they divide India into 5 geographies. And in the 5 geographies, there are randomly selected districts. Each district there are randomly selected villages. And each village 140 people. That's what we get. That's the probability of the sampling for the
That thing is that actually there's no way to really confirm rabies because most of the population, if they had a bite and they died, if they don't have facility to actually confirm the death, they may not know whether that death is actually reflective of human rabies death. So these things they were more sure of, like they could get the dog bite incidence more clearly from the survey, and at-risk population we already have. And therefore they try to put if that is the incidence which we are getting accurately.
another issue maybe in 3 days. One is that the other way would be to count deaths, like how the million death study proposed and this much is the proposed death or something. Now this is, you have told me how many bites happen. And what is it useful for me for public health? I know how straight their dogs are implicated more and things like that. That helps me to focus my efforts. But does it truly give me a reliable number for the overall deaths? Because the entire data, it seems to be if the death, the bite is a very sensitive marker of rabies death, then I agree. But here, there is a lot of assumptions around it. It's a complex question, but getting the data with most of the power for that final analysis comes from your bite data. I'm not very sure, especially there is a jarringly very low number. It puts India in a very good light. I mean, we have come a long way then of the 50,000 proposed deaths, we have 5,000 now. But I'm not sure. The other way I could have done is to stratify based on already known virus predators and see how they are distributed. But it won't give you the true burden of bites, which is a pan-India, which is important for health policy. So I'm not sure. So that is something, this number finally we have arrived at looks a bit shocking, positively shocking, but I hope it is truly the number we should go.
What was the objective of the study that was to?
Annual bite incidence, post-exposure prophylaxis coverage, and human rabies death.
That is the most indirect.
Indirectly arrived at.
That's based on your decision. I mean, you may agree with the decision tree model, you may not agree. you think that you don't agree with it, then you will have to design your own decision. If you say that, okay, this is not the way that I want also to find reason, then you will have to complicate the decision tree further and try to get that data as well. And then
So there is a statement we brought say, all models are wrong. Because all models based on assumption. But some models are useful. So where we can disagree is, they have made a decision tree like this. We have to say that no, I don't think that the probability of byte is 30%, I think it's 50%. I don't think that AP's dog byte chance is 10%, I think it's 50%. So that's how we will disagree with it. But this particular dog byte model is published by WHO. So they use this same model for all countries in the world to estimate dog byte. But I said previously from another method is to do what the global autopsy. You take 1 million people in India, okay? And most of them have not died in hospital. So you go and ask a family member, if you have sudden chest pain and leg disability, if you have cough, fever and blood in children, you die of pneumonia. If you die 1 week after dog byte, you die of rabies. And from that you estimate global, and in malaria season, if you die once after some time, you die of malaria. But that million study has estimated 100 times more malaria deaths than government of India's estimate. India says some 10,000 malaria deaths a year. They have estimated 1 lakh deaths in malaria. So immediately government will that's the wrong methodology. I'm saying, so it's a difficult thing to truly estimate if we don't have good healthcare, good healthcare data. This is one model, one way of doing modeling.
Actually, they mentioned here that there are 3 studies before this which has tried to look at deaths in India from babies. And out of which one was verbal autopsy, which has shown, and 2 other from health data, from data, which has shown around 20,000 to 30,000 human babies death per year. So that is actually, even I was talking, but they have attributed saying from their previous vaccination coverage, the vaccination coverage now is around 10 times more. So maybe that is one of the results why deaths are decreased. So coming to discussion, what we want to look at is again whether they have highlighted all the things that have come out from the results as you are inferring and whether they are trying to ignore certain aspects of it or not. So they have mentioned that death has decreased from 2,000 human babies per year to 5,000, attributing to increased vaccination coverage. However, 20% still do not receive vaccination, which could be because of awareness was one reason, and second was wound time. A lot of people did not take it for operations, so that's something that we need to concentrate on. Second is vaccination of dogs also, which found to be less among pet dogs. And limitations of the study, whether they have discussed everything. So they've done random sampling, but how they have done that, whether it was computerized, whether it was manual, was not mentioned. Again, they could have provided us with their survey forms or data collection forms to know what data they have collected. Then again, why they did not release data of people who had the bites and what happened subsequently to them is not there. Then how they estimated which dog bites were from labeled dogs and which were from non-labeled is not very transparent. And inherent biases of the study, like recall bias and some confounding, cannot be overcome. So coming back to our study, at least from this study, one is we need to intensify our action for total dog-related rabies elimination by 2030. And things that we would want to do is educate about wound care particularly, increase vaccination awareness for timely initiation and dose completion, and increase availability of RIG, although costly because most people are accessing public health platforms, and mass vaccination of dogs. So these are some things that I thought from this slide. Last, just wanted to highlight, this is the JBI critical appraisal checklist for analytical cross-section studies, which again compresses the same questions that we've gone through into 8 questions, mainly from the methodology to analyze your own results and conclusions. Lastly, this is the National Rabies Program plan for vaccination and immunoglobulin based on the type of dog and the type of bite and the category of vaccines.
Thank you, Dr. Sakshi. Today we have had good discussion. Any other questions or any questions from the virtual participants? You may type in your questions through the chat box.
When we said that some animals are offered for 10 days and all, this is all recalled information by the participants themselves.